Hello, everyone. Welcome to session number 5 in our PointRight PDPM educational webinar series. I hope you all are having a great day this spring. So today's session, PDPM Financial Moving Parts, is going to cover, like the title says, all of the pieces that may change or affect your per diem reimbursement under PDPM once we're up and running after October 1st. Before we get started, the usual housekeeping. All the audio lines are muted. So if you have any questions, please use the chat that's built into the GoToWebinar toolbar and type in a message to us. We have a lot of content, but if there is time, we'll do our best to answer questions at the end. And also the handout for this presentation is attached to your GoToWebinar toolbar, so you should be able to click and download the PDF of these slides. And at the end of the presentation, we'll talk about how you can get your continuing education credit. We're as usual, accredited for 1 contact hour for nursing home administrators and 1 contact hour for nurses. Okay, so as usual, our webinar series on PDPM is based on the most current available information that we have. As you know, things keep evolving in this situation, particularly since we now have the fiscal year 2020 proposed rule out. So there may be a little tweaking around the edges of PDPM, but PDPM is going to happen on October 1st. So we're working with the best information that we have at this point in time. Just remember that things may change a bit between now and then. And I wanted to give a little recap on our previous episodes of our webinar series. We're up to episode 5 now. It's a little mini series. Session 1, our colleague Pam Kaiser covered the basics of PDPM, all of the different components, the clinical categories and pieces that are putting the puzzle of PDPM together. And there's a link to watch the recording if you haven't seen it already or if you'd like a little refresher. And then session 2, my colleague Paola DiNatale, who is on the call with me today, covered our non-therapy ancillaries, all the little clinical pieces that put together make up a very significant component of PDPM reimbursement. Session 3, I covered the ICD-10 coding that are going to be extremely important in driving your PDPM reimbursement in a couple of the clinical categories. And most recently, we had session 4. I covered the section GG ADL function score. So all of those pieces are put together in one place. So these are the links to watch the recordings of our previous webinar series. And now we are up to episode 5, which is, as I said, is called Financial Moving Parts. So our learning objectives for today are to cover all of those pieces of the patient-driven payment model system that will affect your per diem rates either through a timed decrease in some CMI categories or through a new assessment. So we'll talk about those pieces. And we'll also talk about how the variable reimbursement pieces of PDPM may factor into your budgeting and your planning and your strategic resource allocation. And we'll always talk about how you can take a look at the systems that you have in your facility and how you can adopt effective changes to help you be ready for PDPM and especially in situations like this, mitigate your risk for potential compliance issues. So with all that out of the way, I'm going to hand the microphone over to my colleague, Paola DiNatale. Paola?
Thank you, Jen, and welcome everyone to our 5th webinar session on financial drivers and moving parts. By now, you may already have this schematic, this PDPM case mix component diagram permanently embedded in the forefront of your brain. I know I do. But we felt important to add this to our session today because at the center of each of these components is the resident care, the resident's clinical conditions, the comorbidities, the ICD-10 coding, all of which is driven from the MDS assessment and the coding that is going to impact each of these PDPM case mix components. Now, moving ahead as far as the variable adjustment factor, which is one of those moving parts. Jen, are we stuck? Oh, there we go. As one of those financial drivers, which I would be speaking on, it utilizes an adjustment schedule, and it impacts 3 of these 6 components. That's your physical therapy, OT, and the non-therapy ancillary, and it will adjust based on the days the resident, or that point in stay since the day the resident was admitted in your facility. So to give you a little bit of background about the variable per diem adjustment factor, the variable per diem adjustment factor, and I'll talk about a little bit about the background, but that is also known as the per diem rate, or the latest CMS acronym VPD. Now, how this started was there was an analysis that was conducted under the SNF Payment Models Research Project, known as PMR, on cost overstay for each of the case mix adjusted payment components to identify the patient-driven payment model. Now, what it revealed was that there were different trends in resource utilization over the course of a SNF stay. And the analysis found that the resource used for certain SNF services was not constant over the stay. So it changed. Now, further analysis conducted by CMS identified that between days 1 to day 20 for PT and OT, they're not combined, it's each one individually, which much higher between days 1 and 20. And for the non-therapy ancillary, the costs were much greater for the first 3 days. Therefore, the decision was made to utilize the variable adjustment factor for these 3 PDPM components, which will adjust based on the residents, that point in stay or that resident stay during the course of their admission, spell of illness. Next slide, Jen. Oh, here we go. The grid for the PT and OT variable per diem adjustment factors. As you can see, between day 1 and day 20, the adjustment factor is set at a 1.00, and this becomes the multiplier. Now, from day 21 on and every 7 days, the multiplier or that VPD will adjust at 0.02, or basically a 2% every 7 days. And based on how long the resident, that length of stay during a spell of illness, is going to adjust this per diem factor. Similarly for the non-therapy ancillaries. Now, for the first 3 days, the adjustment factor is set at 3.00. So that will be the multiplier that will be applied to the NTA base rate, and then multiplied based on the NTA RUG grouper, and the CMI index for that specific group are multiplied by the 3.00, and then from day 4 to 100 is going to reduce to a 1.00, which then it will stay constant, unlike what is going to be happening with PTOT, where it will change, reduce every 7 days by 2%. Now, I believe thank you, Jen. The next slide here. Let's do a little bit of applying this concept to a particular case, the case of Miss Jane Q, 77-year-old female, admitted to the SNF for PT and OT for strengthening following a fall. During her acute stay, a pathological fracture was found on X-ray. She also was diagnosed with COPD with acute exacerbation, and there were no surgical procedures done. Her primary diagnosis code is M800-8XG, which is the age-related osteoporosis with current pathological fracture of the vertebrae, subsequent encounter for fracture with delayed healing. Now, the clinical category for that particular primary diagnosis is non-surgical, orthopedic, musculoskeletal. Next slide, Jen. The PT and OT function score for this resident scenario is 10. The nursing function score is 7. She was diagnosed with malnutrition because of a low BMI. She is receiving a mechanically altered diet. There was no swallowing disorder identified. Her BIM score equals 12 and her PHQ-9 score is a 10. Now, looking at each of the PDPM components and identifying the case mix group associated. Now, all of this was derived from the CMS grouper tool where we applied this case scenario situation to come up with the category. The PT and OT case mix group is a TG, OT, a TG as well. The speech and language pathology, an SE. NTA, there were 2 conditions identified, so that brought it up to an ND. In nursing, because of the cognitive impairment and depression, an HBC2. To the right of that is the PDPM CMI. Now, the CMI stays constant as long as the case mix group is constant. Now, Jen is going to talk about the IPA and interrupted stay, and that would have an impact, obviously, if the facility is going to do an IPA, that may have a change in the PDPM CMI. However, the PDPM CMI is going to stay constant as long as that case mix group, there's no change to that case mix group. So what happens is that based on the case mix group and the CMI, for the first 3 days, and we have kind of like mapped it out as far as what is going to be the total per diem rate for the first 3 days based on what we had just identified with the case mix group and the CMI, the base rate which was obtained from the final rule from CMS, and also applying the multiplier for the PT, OT, and the NTA. For days 1 to 3 is $669.20. Now, on day 4, the NTA variable adjustment factor reduces to 1.00. So the rate from day 4 to 20 is going to be 564.61. The adjustment factor for the PTOT is going to stay constant at the 1.0 because that doesn't change till day 21. So the difference between those 2 per diem rates, now this is each day, is going to be $104.59. So for those of you who are attending this call who are the financial gurus of your facility or on a corporate level, $104 and change may not be of significance, or it may have a huge impact to your financial bottom line or planning your financial budget. Now, similarly, from day 21 to 27, the rate is set at $560.71 because of the PTOT adjustment factor is going to be reducing by 2%. And the NTA stays constant. Now, the difference between the 2 is $3.09. This may be much more acceptable, if you will, when you think about $3 and change. Is that really of significance? Again, it's going to be up to the facility, up to the organization, first of all, to determine what is the volume of the Medicare residents that you're admitted into your building. And what is that impact? And also the length of stay. Do you have a length of stay that is within the first 15 days? Then that impact may not be as substantial. Or is your length of stay greater going into the 25th to the 30th day? Then that may definitely have a per day impact based on those variable adjustment factors. Now, the other impact outside of the variable adjustment factor is coding the assessments and capturing all of those clinical conditions. So we did another exercise, okay? The PDPM payment being $669.20, and we did a what if. What if there was no diagnosis of malnutrition and the NTA drops, right, from an ND to an NE, the PDPM rate now is going to drop to a 639 and change. If there's no cognitive impairment, the SLP drops to an SB for an SE, and that payment is $628 and change. And if there's no depression identified, nursing category component drops to an HBC1, and that rate drops down to $589 So it's going to be very important for the facilities to really remember is that resident care, and that is also a driver outside of that variable per diem adjustment factor. So now I'm going to hand this off to Jen, who will be talking about the interim payment assessment.
Great, thanks, Paula. And you know, that section of your presentation is a good segue to talking about the IPA, because it really drives home the importance of capturing comorbidities and communicating this information in the documentation, particularly diagnoses and assessment of mood and issues and cognitive impairment, to make sure you're capturing the right case mix groups to begin with, because from there, the case mix groups that are captured on the 5-day MDS are what you start with, and it will adjust downward from there. Now, the interim payment assessment is a potential opportunity to bump up those case mix groups a little bit, but there are certain circumstances under which you would complete an IPA. So we're going to go through those criteria, which frankly are lacking a little definition right now from CMS. Sorry, guys, I wish I could give you some more words of wisdom, but we'll work with what we've got so far, and I'm sure CMS will firm up the definitions around the IPA going forward. Now, I hesitate to refer to the significant change in status assessment when I talk about the IPA, but for a little bit of perspective, you know, there are certain circumstances and pretty clearly defined circumstances under which you would complete a sig change assessment. And there are 20-some pages in the RAI manual talking about when and under what circumstances a significant change is required. But those 20 pages in the manual took, you know, how long has it been since MDS 3.0? Since 2010. So it's been almost 9 years since then, while those criteria were continued to be fleshed out and defined more clearly in the manual. I have a feeling once CMS sees how people are behaving and completing these IPA assessments, that we're going to get similar definition around it. But for right now, CMS is kind of abdicating responsibility from creating these criteria for the IPA and delegating it to the facilities. But why do you complete an IPA? So the P in IPA stands for payment. So that should be your clue that the interim payment assessment is completed only to change the resident's classification in one or more case mix groups components. So it's 100% strictly used for payment. It's separate from what you would think of as a significant change in status assessment. The assessment reference date for this assessment can be any date after the ARD of the initial payment assessment or the 5-day MDS. I don't know if you've had a chance to read the proposed rule yet. Honestly, I haven't read the whole thing yet, but I've skimmed it. And one of the things that CMS has mentioned is we're moving away from that terminology because really, once there's a 5-day MDS, there's really nothing in PDPM after that. So they're calling it the initial payment assessment. They're kind of changing that terminology. Now, how long it's going to take us to break us of that habit, it might never happen. But anyway, initial payment assessment, when I say that, I mean the 5-day. So any changes to payment or case mix groups for that resident effective with the IPA will take effect on the assessment reference date of that IPA assessment. But the variable per diem adjustment factor that Paula explained so nicely for us is not affected. So you don't go back to day one of your variable per diem adjustment and get to 3.0 multiplier of your NTAs and go back to baseline for your PT and OT if it's after day 21. Your variable per diem adjustment still keeps going from day one of the resident stay. Now, this is a totally optional assessment. There will be no penalties for missing an IPA. CMS is not going to audit you and say you didn't do an IPA. But on the other hand, CMS is going to be monitoring. They've already said that they're going to watch IPA utilization. So not to scare people away from using them, completing an IPA where it's necessary or where it's appropriate, just know, just like anything else, CMS is going to be watching pretty much everything people do with the PDPM effective October 1st. So I've got one eye on my slide view. Here we go. So what are the criteria for IPA, such as they are? So an IPA is completed when there's a change in the resident's first tier classification in one or more components, meaning PTOT, speech language pathology, nursing, or non-therapy ancillary, enough so that the resident would be classified into a different case mix group in one or more of those items. It doesn't have to be more than one. It could just be one of those case mix components that would be a different classification from the initial payment assessment. So this would result in a change in payment, either in one component or in the overall payment. And the assumption is that this is not going to be any old change that is a transient condition that you jump right on and say, oh, the resident had a fever one day and they were throwing up, so I'm going to capture this because that will change my nursing category. If it's something that's not a transient condition, if you kind of think of those criteria, you know, loosely apply the criteria for a significant change assessment, it's supposed to be something that is not self-limiting and would not just resolve with normal treatment within a 14-day time period. So that's from the final rule. Again, it's not codified in the manual yet because we don't have the manual yet. I keep refreshing the page to see the manual, but it's not there yet. But those are the basic criteria that we are looking for. So when we talk about a change in a first tier criteria for PDPM, what CMS was referring to, and my animations are going to have to catch up with me here, is the first column in each of the tables in the final rule that laid out the clinical categories for RPA. So I just have these screenshots of those tables, and you see the first column in each of those tables indicate what the clinical category is, whether it's for PTOT clinical category, speech clinical category, one of the nursing quote unquote RUG categories, they're still using that term, or the non-therapy ancillary counts. So it's not going to be just any old change. It would be any change that would affect that first column to move the resident into another category in that first column of a table. And that's as close as we have to a definition. Now, the IPA is a separate MDS item set. When CMS first floated the idea, they said, oh, it'll be the same item set as the 5-day MDS. Well, they backed off from that. They've created a new IPA item set, which will go into effect October 1st. It will have it'll be pared down, so only demographic information about the resident and the PDPM payment items are part of that item set. So it's a much smaller item set. And it includes things like the Section GG Column 5 interim performance, because CMS realized that they needed a new column to capture the ADL function scores on that interim payment assessment. So it will be different from what we're used to working with right now. Now, this item set cannot be combined with any other assessment. You're always going to do an IPA separately from any other MDS. So if you also happen to need to do a significant change on that resident because they really did have a significant change in status, they could have the same ARD, but you're going to have to complete them as separate MDSs and submit them separately. Just keep that in mind. The assessment period for the Section GG ends on the ARD, so that's the ARD plus the 2 prior days. That's specifically for Section GG. The other look-back periods, like for the BIMS, for example, have strict time periods, but CMS is still, they haven't quite given us all the details. So I'm waiting to see what Chapter 2 in the REI manual has to say about those look-back periods. But the ARD, as usual, will be the end point of that time period. So CMS is expecting that facilities are going to develop an IPA, policy. I'm not sure if they need something that is written policy and procedure, but that facilities are expected to develop their IPA criteria and apply them consistently. So, so far CMS has said, nope, we're not creating any more formal definitions for the IPA beyond what we already have. And so it's up to the facilities to determine when an IPA is appropriate. Now, remember, the IPA is 100% optional. You don't have to do an IPA ever, but you're going to want to do an IPA if it's going to increase your reimbursement. So then it becomes a question of when is it worth your while and your effort to complete this IPA assessment. So it would depend on what the resident's baseline acuity is captured on that initial payment assessment, what types of specialty care services they're receiving might really increase the non-therapy ancillary count, for example. So basically, this is going to require a lot of communication among the members of your interdisciplinary team, so you know when that IPA is going to be completed. Now, that means the interdisciplinary team needs to know what to look for. But CMS has also said in the final rule, hey, guess what? We do expect you to continuously evaluate and adjust to changes in the resident's condition. That's something we do anyway, just as part of basic standard clinical practice. So make sure you're documenting and communicating this so that when it will benefit you by achieving a higher CMI for a category, you can take advantage of it with an IPA. Now, as I mentioned, an IPA is not intended to be for any old change in the resident's condition. So it's up to you on a case-by-case basis to determine when a change in the resident's condition is IPA worthy, which is not a term, but I'm going to make it one. So not any old change in the resident's condition is going to be considered IPA worthy. So it's up to you to determine what's driving the resident's clinical categories, what's driving their reimbursement, what did you capture on that initial payment assessment, so that you know what areas of change are potentially going to occur for that resident. What are their current diagnoses? Is there a potential for skin breakdown or the need for a special treatment or procedure based on their diagnoses? Did the resident come in as totally non-ambulatory, and now that they're up and about, there's other things that you are doing for them that you could capture a higher case mix group for. Now, also you need to be aware of when that change is enough to impact the payment itself, because sometimes the resident is going to have a certain number of NTA points, and adding one more NTA point is not going to be enough to change the payment. So don't overdo it and don't make work for yourself that you don't have to do. And as I said earlier, you're monitoring the resident, you're looking for changes in the condition, and under OBRA, you, in some cases, are required to complete a significant change in status. So also assess to determine if that is necessary. That SIG change is going to need to be completed separately from the IPA. So as I said, you could complete 2 MDSs with the same ARD. So technically, you're only doing the assessment once and just completing 2 separate MDSs and submitting them to CMS separately. So it's a matter of working out that process rather. So here's some more animations that hopefully I'll be able to stay ahead of. So I have a few examples that, what if you have a resident who comes in and you complete the 5-day and the resident's case mix group in nursing is HBC1, that's a special care high, folks, by the way. And he develops pneumonia with a fever on day 12. Well, you would not complete an IPA. You might think you do because a fever and a pneumonia is a case mix group driver, but it would not change the resident's case mix group classification because he's already special care high. So that's not going to change that classification. So no IPA in that case. Now, let's say if the resident has an NTA case mix group of ND. So the score is 5 for COPD, diabetes, and morbid obesity. And she develops a diabetic foot ulcer, or it's documented on her right foot on day 8. Now, that in fact would change the case mix group because her score is 5. that diabetic foot ulcer would bump it up to a score of 6. So that would move her case mix group to an NC. And on day 8, you know, you don't have to worry about any other variable per diem adjustment in the non-therapy ancillary because it's already happened. So you may very well complete an NTA in that case if it's enough of a change to justify the completing of the MDS and the assessment. The third example, let's say the resident's PT-OT case mix group is a TF, so they've got a function score of 7, they are max assisted bed mobility, they're non-ambulatory, so transfers and walking did not occur. But by day 7, they're up and out of bed, PT and OT are working with them, bed mobility is partial to moderate assistance, transfers and walking are substantial assistance, but they are occurring. So that's a big change to the PT-OT functional score. So that would, in fact, change the case mix group to a TG because their function score is now a 10 because they can score them, the resident on walking now, what they couldn't before. So that, in combination, you know, there could be other changes as well, might justify completing an IPA because that would change the case mix group. Now, PT-OT does not begin to adjust downward until after day 21. And we're talking day 7 here. So if you set the ARD for day 7, you could also get a higher case mix group before that adjustment begins after the 3 weeks. So hopefully those examples, you know, gave you something to think about. Like I said, there's not a lot of definition around the IPA policy as of yet, but I think you'll get the feel for at what point does it become worth your while to complete that assessment and achieve a different case mix group. But next we're going to move on to the interrupted stay policy because this is something that is new to the SNF world. CMS has said in their final rule that there's a similar policy in other post-acute care settings, so it's really kind of bringing the SNF world along to the same type of policy that allows multiple stays, quote unquote, under the same Medicare benefit to be treated together as a single interrupted stay. And what this means is that you don't need to complete a new 5-day initial payment assessment under those circumstances. So what is considered an interrupted stay? It's any time that a resident is discharged from the SNF or from a skilled Medicare level of care and returns to the SNF or to the skilled level of care within 3 calendar days, with the day of discharge being day 1. Now, the couple of asterisks on this, they have to return to the same SNF following discharge if they leave the facility, and the skilled level of care if they go back to a skilled level of care following the notice of non-coverage, if they go back to that previous skilled level of services within 3 calendar days. So if both of those criteria are met, then you can attach to that prior stay. You don't have to do a new 5-day. Now the variable per diem, again, variable per diem is hard and fast. It does not change due to an IPA. It doesn't change due to an interrupted stay. It will pick up from the day of discharge. So for example, a resident's discharged to the hospital on day 12, and he returns within 2 days. The date of return becomes the new day 12. If you think about it, that day of discharge was not a Medicare billed day. So now you're back, the resident's back, so this is the new day 12. Now this is counting calendar days. This is not a midnight rule. So for example, if I get discharged to the hospital tonight at 11:45 p.m. and I come back tomorrow morning at 6:30 in the morning to the SNF, that's 2 calendar days, even though it's only 1 midnight. So it's a different concept. It's a pretty straightforward concept, but it's different from what we're used to dealing with the midnight rule. Now, the interrupted stay policy is pretty clear cut, but when the resident comes back, you might complete an IPA at your discretion, depending on if there are changes in the resident's condition that would meet those criteria, meet that threshold for completing IPA worthy. But that variable per diem schedule, again, will pick up right where it left off on the day of discharge. So I have a couple of examples of what may or may not be an interrupted stay. Like I said, this is a bit more clear cut than the IPA policy. So let's say that the resident goes to the hospital, their discharge return anticipated on Tuesday at 2:30 p.m. And then they're readmitted to the same SNF on Thursday at 10:15 a.m. So Tuesday, Wednesday, Thursday. That's within 3 days. You can make this an interrupted stay, pick up where you left off on Tuesday. Now let's say the resident drops below a skilled level of care and coverage is cut effective Friday. But then on Monday, the SNF's interdisciplinary team says, oops, we forgot about this piece of nursing monitoring and shortness of breath, and we're doing wound care. Oopsie. So skilled nursing coverage should resume, and the interdisciplinary team has determined that on Monday. Well, that's not an interrupted stay because we're looking at Friday, Saturday, and Sunday with no skilled coverage. So that's 3 calendar days that it doesn't pick up again until Monday. So that is not an interrupted stay. You can pick up skilled coverage again, but you'd have to complete a new 5-day with a new variable per diem. Now, let's say the resident is discharged, return anticipated to the hospital Tuesday at 2:30 p.m., but then they're admitted to a different SNF on Thursday at 10:15 a.m. That's still within 3 calendar days, but this is not to the same SNF. So guess what? That other SNF has to do a 5-day. They can't pick up from your 5-day. They have to do their new assessment, set their new initial payment assessment, and take it from there. So that is not an interrupted stay. I have a couple more scenarios for this. Let's say that a resident is discharged, return anticipated to the hospital at Tuesday at 2:30 p.m. because that's our time to discharge people to the hospital. And then they are readmitted to the same SNF on Friday at 10:15 p.m. So now we've got Tuesday, Wednesday, and Thursday. We've passed our 3-day limit, 3 calendar day limit. So Friday is day 4. So that is not an interrupted stay, and a new 5-day would be required to pick up Medicare coverage. Of course, if we drop a resident below a skilled level of care and discontinue Medicare coverage on Monday, but then on Wednesday we realize, oops, interdisciplinary team meeting, we really should have maintained skilled coverage. Let's pick them back up again for skilled nursing services. That is within the 3 calendar days, Monday, Tuesday, Wednesday. So we could call that an interrupted stay and pick up where we left off on Monday. So these, like I said, these examples are much more clear cut than determining whether or not an IPA is required, because there's only 2 things you have to track. How many days since the date of discharge or drop in skilled services, and was the skilled care resumed at the same SNF within 3 calendar days. And that's all you really need to keep track of for an interrupted stay. So this goes into process. And remember, if you're discharging a resident from the SNF, the OBRA requirements are not going anywhere. So that discharge MDS would still be required for a discharge from the facility, whether it's to the community, to the hospital, to another SNF, another care setting. So you're still going to have to do that OBRA discharge MDS. So just in case, if there's any chance the resident might come back to you within 3 calendar days, complete the discharge MDS. You're going to have to do it anyway with the ARD of the date of discharge, but hold on to it. Keep it in your pocket and wait 3 days. Wait to see if the criteria for an interrupted stay are met. If the resident comes back to you at a skilled level of care within 3 days, then you don't code that discharge MDS as a Part A PPS discharge assessment in A310H, and then you go ahead and submit the MDS to CMS. If the resident does not return within those 3 days, then you would code it as a Part A discharge and go ahead and submit. But it's that one MDS item that you could wait, hold on, don't submit the discharge until you're sure whether or not you're going to code that assessment as a Part A discharge. So it's all in managing your process. You can hold on to that MDS for a couple of days before you click submit. Now, if a resident drops below a skilled level of care, but they stay in the facility, so you're going to complete a PPS discharge MDS because they're not discharged from the facility, but you have to show this was the last day of skilled Medicare coverage. So you are going to have to do a PPS discharge standalone assessment. But again, just wait. You can start the MDS with the correct ARD, the date that coverage was discontinued, but wait 3 days before you submit it. And if the resident remains below a skilled level of care after that 3 calendar day time period, then you can go ahead and complete the MDS and submit it. If the resident resumes a skilled level of care within 3 calendar days, then there's no discharge required. But you will want to assess the resident for potential interim payment assessment and/or a significant change assessment. So it's managing the process, and that's where your nurse assessment coordinators are going to really, even more than usual, show their value because they understand the parallel requirements of OBRA discharge assessments and PPS discharge assessments and where they can be combined and where they should not be combined. So it's all a piece of coordinating that MDS process. So we're going to start talking about putting the pieces together because hopefully the whole intent of our webinar series is to help you put these ideas into practice in your own facilities. You have your own processes and procedures in place right now to manage to the RUG world. Now we're going to talk about applying those same processes to PDPM without completely bulldozing everything and starting from scratch. So Paola, I'm going to cede the floor to you to get us started.
Up to this point, you've heard both Jen and I speak about these moving parts, all of which can potentially influence or have a direct impact to the reimbursement, to the per diem rate. So thinking about operationally, and now I want to target those of you who have called in, who have a financial interest. Okay. Now, CMS rolled out a few months ago where they released a CMS impact analysis report. Now, one of the questions that I want to ask you is, have you at your facility reviewed that report? Have you conducted an analysis? How does that play out with the operating costs? Now, we all know that with the budget planning, we have to plan for those internal and external drivers. Have you identified those? And what are those? And what is the maximum impact to the business? Also, have you taken into account any fluctuations in the operating budget and allow for necessary adjustment? Now, the next slide, these are questions I'm sure you all think about this. I know as a former administrator myself, every time during budget planning or questions that we started early on to plan ahead to identify how did we do the past fiscal year currently with our operating costs, and moving forward, what are some of the challenges that we're going to be faced with? So the factors to consider having those 3 questions in mind. First of all, I spoke to you, I provided to you with some examples and scenarios, how there will be some variations with the variable per diem adjustment factor based on the length of stay. If you have a lengthy length of stay, and sorry for the same use of words there, but if your length of stay for your Medicare residents is greater than 20 days, that may pose a significant challenge financially in your facility, and that may be an area that you need to take a closer look to do some root cause analysis to find out what are the reasons that they cannot be discharged, whether back out to the community or cut from Medicare because they met their skill level of needs. So we spoke about the PTOT adjustment in the NTA and the impact that can have financially, and you may think it may not be significant enough, or it may be so. The internal and external drivers, and let's face it, even though you may budget for them, Sometimes they rise above that, and there may not be significant monies in that budget to allow for those drivers. And I'm speaking to staffing, staffing retention and staffing attrition, even though we budget for those, things become unexpected. What happens in our facilities where we're into the role of trying to hire new staff and educate, and all of that does add, it's costly, adds more money. What about, have you taken a closer look at your contractual agreements with your vendors, especially with all of this change with PDPM, or your vendors ready? What about the renegotiation or the contract agreement with your therapy department? Obviously, they're not going to be totally extinct from PDPM. They're still going to be highly involved in providing therapy modalities to our residents as needed. And if you happen to, your facility is in a state where there may be some Medicaid reimbursement issues, or they're more per diem based because of cost reporting. And I don't believe that there's too many states that still operate that way, but I know that there's still some. Primarily, most states now have gone through a Medicaid reimbursement methodology. Your facility may be struggling with that as well. And occupancy, there's definitely fluctuations with occupancy. And what, from your facility perspective, have you put in place to, as far as marketing strategies, communication with your hospitals, nearby hospitals, physicians, to as far as increasing that bed occupancy and ensuring that your facility is well equipped and competent to address the needs of the resident? Also, the needs of the residents can cause major fluctuations in the operating budget, as well as the educational needs of your staff. And we all know right now that there is a great deal of education that needs to take place in our facilities, especially with PDPM. We've been pretty much status quo with the Medicare PPS, and now it's going to be this hard switch effective October 1st. We still have some time, but the days keep on going by very quickly. So what are some of the strategies to mitigate some financial and compliance risk? Now, these three strategies, like planning, setting up goals, and periodically evaluating, are not anything new or foreign to us in the long-term care industry. We always set up strategic planning, but it's very important to identify what are some of those high-risk areas. I started off with those three questions and identify what were some of those areas that can impact, first of all, your operating budget as you plan for your next fiscal year, and also looking through history, what has been some of those fluctuations and adjustments that you've had to make that have been quite costly. So set those goals, identify, prioritize, and as always, we monitor and manage and revise the plan accordingly. And periodically, we need to evaluate those benchmarks and what are those key financial drivers. And I believe that with PDPM is going to provide us with that opportunity as we move forward to be able to be closely focused on that. So now I'm going to move it back to Jen, who is going to talk more as to the IDT collaboration and communication perspective as setting up some of those strategies to operationalize and help you through this process. Go ahead, Jen.
Exactly, Paula. Yeah. So, and that's exactly it. Paula is thinking strategically from the organizational or the single facility, the nursing home administrator's perspective. I, as an MDS coordinator, am thinking about the interdisciplinary team communication and what systems we already have in place, like our daily Medicare meetings and our triple check. How are we going to adjust this to the PDPM component? And I suggest turning your daily Medicare meeting on its head, because usually, historically, throughout the RUG-based system, the first question you ask about just about every resident on your Medicare caseload is how many minutes did they get yesterday? And what would the RUG be today if we were to set the ARD? So turn that on its head, because, therapy, again, We love you guys. You're very important. But as far as reimbursement is concerned, we need to be hearing from the nursing department and restorative team, social service, dietary, the physician's documentation, the nurses on the floor. These pieces will drive PDPM rather than therapy minutes. So these interdisciplinary team meetings, which should be discussing the resident's condition, how they're doing, what changes have happened since the last day, aren't normally discussed to drive RUGs, but they should be discussed anyway because it's a care collaboration meeting more than counting minutes. So, but the good thing about that, because that should be happening anyway, is you'll get reimbursed accordingly. But be prepared to, fire off the starting gun and complete an IPA, including section GG, the BIMS, the PHQ-9, when you identify a change that is IPA worthy. And the ARD of that assessment is the date that the payment changes. You don't really want to delay in setting that assessment reference date once you identify the change. Now, I do want to remind everybody that the skilled level of care requirements are not going anywhere. They're not changed. I won't say they're carved in stone, but they're not changing. So a skilled level of care under Medicare requires a physician's order, skilled nursing and or rehabilitation services provided by or under the supervision of a licensed professional, provided on a daily basis, which for nursing is defined as 7 days a week, and for therapy is defined as 5 days a week. Provided for a condition for which the resident received their inpatient hospital care or which arose in the SNF while receiving care for that inpatient stay. And as the practical matter clause, the services can only be provided in a SNF on an inpatient basis. Otherwise, the resident could be going home with skilled services. So those level of care requirements, if you don't already have them tattooed under your eyelids, are not going anywhere. So remember that, because CMS has been saying continuously now, every time they get up and speak about PDPM, stop thinking of skilling your residents for nursing or skilling your residents for therapy. That's not the perspective that CMS wants us to take, and it shouldn't be the perspective we take, but we've kind of evolved into it because we were driven that way by RUGs. The residents should just be skilled for nursing care or SNF care, let me say, or rehabilitation care. It all is skilled for SNF level of care. So rethink how you think about this. These 5 broad categories of skilled care are directly from the Medicare Benefit Policy Manual, Chapter 8. That's still the go-to manual for determining if a resident meets the criteria for daily skilled care in a SNF. So refer to those, because these are things beyond skilled rehabilitation services that if you could document that you're providing those services on a daily basis, then the resident meets that threshold of maintaining that skilled level of care. Now, just a reminder, Paola mentioned the hard switch. It's still going to happen. October 1st, 2019, we are flipping the switch from RUG-4 to PDPM because there's no other way to transition. So every resident in your facility who's currently covered under Part A during this time period, you're going to need a RUG for that assessment with an ARD before October 1st so that you can bill through September 30th under RUGs. And then every single resident on your Medicare caseload is going to need a transitional IPA assessment. So this is the one and only time an IPA is going to be mandatory. The ARD has to be no later than October the 7th. So October 1 will be day 1 as a variable per diem adjustment factor for everybody. So this is the only time where it's kind of carved in stone for everybody. Their VPD is going to start on October the 1st. So I hesitate to say no vacations that week, but it is really going to have to be all hands on deck, because everybody, depending on how many people are on Medicare caseload that week, everybody's going to need an IPA. So make your strategic plan now to handle this switch, because you're going to be busy that week. So make sure that you're assessing Section GG interim performance for all these residents, doing the BIMS, doing the PHQ-9. Remember, October the 7th is on a Monday. So if you can avoid it, you might, not that your weekend staff cannot handle this, because they certainly can, and they're going to have to learn to if they can't. But make sure you're planning accordingly for this, because your deadline is going to be on a Monday. So you'll have to do at least some work over the weekend. All right, well, we've covered lots of ground and we are almost out of time, but just to wrap things up, as usual, we try to give some references here. So this is the same PDPM website that CMS has been maintaining. They updated it very recently with a new FAQ document and new calculation worksheets and clinical category mapping. So always go to this page for the source reference. I've also put up a link to download the Medicare Benefit Policy Manual. It hasn't been updated in a couple of years, but it's always good to have a copy that you can refer to if you need to refresh your memory. And we're happy to help you if you have any questions. Our contact information is in the handout. Our next session, we don't have a date for you yet, but it's going to talk about compliance, because we're going to have to go there. Areas that are going to put you at risk for potential non-compliance. So Paola and I are very happy to have you on this call today. And here's what you've been waiting for: how to get your CEUs. So again, we are approved for 1 contact hour for nursing home administrators and 1 contact hour for nurses. But you will need to complete our evaluation survey. So this is the link to the Survey Monkey. We will also be emailing this out with our follow-up email after we get the attendance report. So whoever logged in to this webinar session will receive the email, or you can go straight to this link. If you receive the email, you have multiple people attending along with you in the same room, just forward that email to them so they can each complete the survey, because everybody will need to fill out the survey and that information so that we get our final attendance list. So please complete that survey and fill out your information by Friday, May 3rd. So we'll give you a little over a week. For your nurses, once you complete the survey, tell us you're a nurse. You'll be able to download a certificate of completion. For nursing home administrators, as you know, the National Association of Boards is managing their CEU registry now. So please give us your NAB ID number. Once we get that final list, we'll report to the CEU registry, and your attendance will be tracked centrally at NAB. Okay, well, we have no time left, so we do apologize. I see there may have been some questions here, so I'll pull the report and respond to you via email. But thank you so much for joining us today. Paola, thank you. As usual, it's always a pleasure to work with you.
Oh, thank you. Same here, Jen. Thank you, everyone, for joining us today.
Have a great day. Take care.